I'm Joan Mortimer. I'm the director of our Women's Cancers Program at City of Hope, and I'm going to talk about leveraging clinical pathways in the setting of metastatic breast cancer. These are my disclosures, and these are the learning objectives that we will accomplish over the next 35 minutes. So there have been a number of new agents in the management of metastatic breast cancer, and I'm going to start with the HER2-positive breast cancers. And I'm going to start by reminding people what the value of guidelines are, and they basically revolve around FDA approval as a starting point. The purpose of the FDA approval is really to review the data to ensure that the benefits of the drug far outweigh the risks in the targeted population. And FDA approval does not supplant the need for us to be clinical physicians. So the first drug I'm going to talk about is neratinib, which is not a new drug. It was approved in the adjuvant setting of HER2-positive breast cancer. What is new is the publication of the NALA trial. Neratinib is a dual EGFR HER2 inhibitor that was tested in the setting of women with metastatic HER2-positive breast cancer who had received at least 2 prior therapies for metastatic disease. They had a good performance status and documented HER2 positivity. What is unique about this study is that it included patients with brain metastases that were stable or asymptomatic. At the time the study was designed, the control arm for second-line therapy would be lapatinib and capecitabine. Neratinib was combined with capecitabine and given on a 21-day cycle. Now note that the capecitabine dose in the neratinib arm is 1,500 milligrams per meter squared twice a day in a 21-day cycle. This was dose reduced because of the concern of diarrhea enhanced with neratinib. The capecitabine in the neratinib arm was 2 grams per meter squared, again, day 1 through 14. So the co-primary endpoints for this study were progression-free survival and overall survival, and secondary were the CNS time to intervention. This slide looks at the co-primary endpoints of progression-free survival, which favors the use of neratinib over lapatinib in combination with capecitabine, with the progression-free survival advantage of 2.2 months. The overall survival advantage was not statistically significant, though PFS was in fact statistically significant. We all recognize that lapatinib has activity in the brain, as does neratinib, and it is most impressive that the time to need for CNS intervention was statistically in favor of neratinib. Know that there were roughly 50 patients in each arm that had brain metastases at the time of study entry, and again, this was statistically significant that the time to need for intervention for CNS disease was statistically significantly prolonged for those patients receiving neratinib and capecitabine. Trastuzumab Deruxtecan is an antibody-drug conjugate with trastuzumab and a Deruxtecan-like drug. The study population for testing Trastuzumab Deruxtecan were women with heavily pretreated HER2-positive metastatic breast cancer. The population was 184 women, all of whom had good performance status, some of whom were hormone receptor positive. But the impressive part of this study is the number of prior treatment regimens that these individuals received. The median number of treatments prior to receiving Fam-Trastuzumab Deruxtecan was 6, with a range of 2 to 27. All had received prior trastuzumab, all had received prior TDM1, and most had received pertuzumab as well. Many had responded to TDM1 in the past. This may be one of the most impressive waterfall plots in drug development. This study included 168 patients for evaluation in this waterfall plot. And as you can see, only 4 patients demonstrated disease progression. The other 164 had some evidence of tumor shrinkage with this drug. The duration of response in the patients who are evaluable for response is shown here and is 14.8 months. The progression-free survival for the overall population is 16.4 months. 24 women with asymptomatic brain metastases are included in this trial, and the median progression-free survival was 18 months, and that's pretty comparable to the overall progression-free survival for the entire population at large. It's worth reviewing this adverse events for this drug because it is a new agent, and recognize that nausea is a major side effect in roughly 3/4 of patients, fatigue in 50%, alopecia in 50%, vomiting 50%, and constipation in almost 1/3 of patients. But the side effect that we most need to keep in mind is that of interstitial lung disease, which was reported in 13.6% of patients. Now, most of these women had received higher doses than the currently approved dose for trastuzumab deruxtecan, but it's important to recognize that patients who are short of breath on this drug need further evaluation to ensure that we identify interstitial lung disease. If it happens, we identify it early. So the first antibody drug conjugate that we had, it was TDM1. And this next slide compares the difference between TDM1 and Fam-Trastuzumab deruxtecan. For TDM1, the toxin attached to trastuzumab is a maytansine derivative and is deruxtecan for the new agent. The ratio of drug to antibody is 3.4 with TDM1, and it's 8 for the new agent. Then this new drug has a very high membrane permeability, and as a result, there may be release of the drug as a bystander effect, and it may turn out that this agent is more active not only in HER2-positive breast cancers that are 3+, but cancers that express 1 and 2+ HER2 as well. TDM1 was approved as second-line therapy, and it was compared to capecitabine with lapatinib. The response rate was 43.6%. In the initial evaluation of trastuzumab deruxtecan, the response rate was 74%. Progression-free survival, 9.6 months compared to 16.4, and these were, again, really heavily pretreated patients. In the approval, patients with CNS disease were included. So there are some interesting differences between these two antibody drug conjugates, but both are obviously very important drugs in the management of metastatic HER2-positive breast cancer. Tucatinib is another new agent. So this is a tyrosine kinase inhibitor of HER2, and the HER2 CLIMB study included patients with HER2-positive metastatic disease who had been previously treated with trastuzumab, pertuzumab, and TDM1. They had a good performance status. Again, patients with brain metastases were included. A brain MRI was required at baseline, and patients who had brain metastases were included if their metastases were stable, if they were untreated but not in need of immediate therapy, or who had been previously treated and may have been progressing but did not need immediate therapy. So the randomization 2:1 to tucatinib with trastuzumab every 3 weeks and capecitabine at a dose of 1 gram per meter squared twice a day for 14 days in a 21-day cycle versus a placebo with the same trastuzumab and capecitabine. The primary endpoint was progression-free survival. Secondary endpoints were overall survival and progression-free survival in patients with brain metastases. This is a slide summarizes the patient characteristics, which are similar to the previous studies, but what I want to point out here is that there were 198 patients in the tucatinib arm who had brain metastases, 93% in the control arm who had brain metastases. If we look at the number of prior lines of therapy, it was 4 for both groups, and as treatment for metastatic disease, a median of 3 prior therapies. This is the Kaplan-Meier plot of progression-free survival, which, as you can see, favors tucatinib. There is an improvement of 2.2 months in progression-free survival for those women who received tucatinib. If we look at overall survival, the co-primary endpoint, again, survival was advantageous in the patients who received tucatinib with a 4.5-month improvement in overall survival. So another secondary endpoint was response, and this slide summarizes the differences in response. Complete and partial responses were seen in 41% of patients receiving tucatinib compared to 23% in those patients who did not receive tucatinib. Adverse events were exactly as you would expect with the use of capecitabine, so palmar-plantar erythema, diarrhea, nausea. The most common side effect that is attributed to the addition of tucatinib is elevation in liver function tests, which were roughly 2 to 3 times higher with tucatinib, but by and large did not result in change in dose or removal from study. So let's look at the group of patients who had brain metastases. Again, it's roughly 48% of patients in this study had brain metastases. And if we look at the CNS progression-free and the overall survival, you see an advantage to tucatinib. So amongst the 291 patients with brain metastases, the objective response rate was 47.3% in those receiving tucatinib and 20% in the control arm. And the progression-free and overall survival was substantially increased with the addition of tucatinib. So this is a very important drug in a disease for which brain metastases are very common. So the current NCCN guideline recommendations for treating metastatic HER2-positive breast cancer have really changed this year with the addition of 2 very active drugs. So first-line therapy continues to be trastuzumab, pertuzumab, and a taxane. Second-line therapy and third-line therapy is either Fam-Trastuzumab Deruxtecan or tucatinib, capecitabine, and trastuzumab. So second and third-line therapy are one or the other of these 2 drugs. But with disease progression, there are a variety of additional drugs which are also effective. TDM1, trastuzumab with additional chemotherapy, lapatinib with capecitabine, neratinib and capecitabine. This has truly become a chronic disease. It's important to note that at ASCO 2 years ago, the survival data for Cleopatra was presented, and those women who were treated with trastuzumab, pertuzumab, and a taxane had a 38% likelihood of being alive at 8 years. So this truly is a chronic disease. So the data that support benefit for survival are really robust for all of these agents. The toxicities of these drugs are really manageable. But of course, these newer agents are extremely costly. And how can costs be contained for this chronic disease? The NCCN guidelines actually endorse biosimilars. So we can take coverage in the endorsement of these 5 biosimilar trastuzumab agents, which really do help to contain costs. On the other end of the spectrum, you may be aware that there are subcutaneous administrations for trastuzumab and pertuzumab, which have been approved. And these are at the opposite end of cost containment, unfortunately, but are very convenient from a patient standpoint and have been endorsed for comparable efficacy by the NCCN guideline panel. Let me move to the third antibody drug conjugate in metastatic breast cancer, sacituzumab. The antibody targets the antigen TROP2, trophoblast cell surface antigen 2, which is not unique to triple-negative breast cancer. It is present in hormone receptor-positive breast cancers as well. But what I'm going to report on here is the use of this antibody drug conjugate in triple-negative breast cancer. The study design included women who had at least 1 prior treatment for metastatic triple-negative breast cancer. They had to have organ reserve, and because triple-negative breast cancer also is associated with a high incidence of brain metastases, patients with brain metastases were included, but only if they had treated asymptomatic brain metastases and could not have had evidence of disease progression for over 3 months and could not be on steroids. Sacituzumab is administered on a day 1 and 8 21-day cycle. The primary endpoint of this study was progression-free and overall survival. So this is the study population, and I review it only because it's typical of a metastatic triple-negative population. Patients, virtually all had received a taxane, most had received an anthracycline, and the majority of patients, 3/4, had visceral disease. So this is typical triple-negative breast cancer with a high incidence of visceral disease. This slide summarizes the response rate. The objective response was 33%, and when you add clinical benefit, that is stable disease for 6 months or more, 45% of women experienced clinical benefit. The median progression-free survival for this drug was 5.5 months. So the NCCN guideline recommendations for the use of sacituzumab is to add it as a recommended treatment in triple-negative breast cancer. And the indication per guidelines is that it be used in patients with triple-negative disease who have received at least 2 prior therapies for metastatic disease. So I'm going to digress and talk about eribulin. I'm talking about eribulin because the design for the EMBRACE trial that led to eribulin's approval has really set the sort of standard for how new drug design is being constructed now. So eribulin was approved in the treatment of metastatic or locally recurrent patients with breast metastatic disease who had received 2 or more prior regimens as treatment for that disease, and they had to include an anthracycline and a taxane. What was unique about this study design was that patients were randomized to receive eribulin or physician's choice. So there was no specified chemotherapy regimen. It was up to the treating physician to decide what chemotherapy they used. So this slide summarizes what those physician choice treatments were, comparing to eribulin. And the primary endpoint of this study was overall survival in the intention to treat population. Eribulin was shown to have an overall survival advantage even in this heavily pretreated population of patients, and it ultimately is approved in the management of this group of patients. And again, this is not just triple negative, it's metastatic breast cancer patients. But the very unique trial design used in EMBRACE has now been used in the design for other studies, and I'm going to talk about one of those now. Keynote 355 was a study in triple-negative breast cancer that were previously untreated or untreated locally recurrent triple-negative breast cancers, but those women had to have treatment for a curative intent of the primary disease. This study looked at the addition of pembrolizumab in conventional doses every 3 weeks with chemotherapy or a placebo. The treatment were either nab-paclitaxel, Taxol, or gemcitabine with carboplatin with an AUC of 2 given day 1 and 8 and a 21-day cycle. The primary endpoint was progression-free survival and overall survival with secondary endpoints of duration of response, safety. This slide summarizes the patient population, and I just want to focus on the PD-L1 positivity. Patients who had combined positive scores of greater than 10 were considered strongly positive, but greater than 1 was positive, and the majority of patients had some degree of PD-L1 positivity. Most of the patients received gemcitabine and carboplatin. About a third of patients had de novo metastatic disease, which is higher than the population that at large, which is roughly about 5% of patients. So what is reported in the patients who have the highest expression of PD-L1 is a significant improvement in progression-free survival. So there is a 4.1 month advantage to the addition of pembrolizumab to chemotherapy in progression-free survival. If we look at patients with CPS scores of greater than 1, that advantage is still seen, though the advantage is somewhat less. A 2-month progression-free survival advantage with the addition of pembrolizumab. So the conclusions of this study is that the addition of pembrolizumab to chemotherapy as first-line therapy for metastatic triple-negative breast cancer did improve progression-free survival compared to chemotherapy alone. And that progression-free survival advantage was greatest in patients with higher expressions of PD-L1, but it was also independent as long as there was PD-L1 expression. I did not review the adverse events and the immune-related adverse events, which were more common with pembrolizumab and were as the side effects that we're used to seeing with its addition. Another PD-L1 inhibitor is atezolizumab, and this is the IMpassion 130 study that looked at untreated metastatic or inoperably locally advanced triple-negative breast cancer patients. And they were randomized to receive nab-paclitaxel with atezolizumab or with a placebo. The primary endpoint was progression-free survival according to PD-L1 expression or not, overall response rate, and of course safety and tolerability. This slide summarizes the characteristics, and I won't belabor the point, but largely these are patients who have visceral metastases, who have a good performance status, and who have received and who have a number of sites of metastatic disease. If we compare the response rates side by side, this is the entire group of 451 assigned to the treatment arm compared to the placebo arm. And if we break out the response rates according to PD-L1 positivity, we see that the complete response rate is significantly higher, 10.3% for those that are PD-L1 positive compared to 1% in the control arm. Partial responses were seen in 48.6% with atezolizumab compared to 41% in those with PD-L1 positive. The median duration of response was 8.5 months for those that were PD-L1 positive and receiving atezolizumab compared to the control arm that were PD-L1 positive of 5.5 months. So this was statistically significant. This looks at progression-free survival by curves. This is the entire group of patients in the intention to treat arm compared to the PD-L1 positive patients. And so very clearly the advantage of this drug is in the PD-L1 positive population. Overall survival did not show an advantage again in the overall group, but in the PD-L1 positive patients there was an improvement in overall survival. The median overall survival was 15.5 months in the control arm and improved to 25 months in those women who received pembrolizumab. This slide summarizes the adverse events, which I think are exactly as we would expect. Peripheral neuropathy was actually pretty comparable. Alopecia was comparable. Pyrexia and hypothyroidism was more common in those women who received pembrolizumab. So within the past 2 months, we've had a report from IMpassion 131. This was essentially the same study design with previously untreated metastatic triple-negative breast cancer patients who were PD-L1 positive, and patients were randomized to receive atezolizumab with paclitaxel instead of nab-paclitaxel, and the control arm was a placebo with paclitaxel. In August, there was a press release from the company that indicated that the primary endpoint of progression-free survival was not achieved with the use of paclitaxel and atezolizumab. So the current NCCN guideline recommendations for atezolizumab is for triple-negative breast cancers. You should assess PD-L1 expression on the tumor-infiltrating immune cells to identify who is most likely to benefit. And the chemotherapy drug is albumin-bound paclitaxel. So the data for nab-paclitaxel in metastatic disease is equivalent to paclitaxel. So why is IMpassion 130 different than IMpassion 131? Is it the measure of the PD-L1, which is complex and its measurement is not entirely agreed upon by pathologists? Or is it the fact that IMpassion 130 used nab-paclitaxel, which does not require steroids for administration, and 131 used steroids, and perhaps that had an impact on the benefit of a PD-L1 inhibitor? This slide summarizes the guidelines, the NCCN guidelines for systemic therapy in metastatic disease, and there is a wealth of available agents for the use of for the treatment of metastatic breast cancer, all summarized here. I'd just like to comment on 2 new agents which have some very exciting preliminary results that may be discussed within the next year. So ipatasertib is an AKT inhibitor which has shown activity in patients who have AKT mutations, and lenvatinib is a multi-kinase inhibitor, VEGFR, FGFR, alpha, KIT, and RET. And it is being tested currently in the setting of metastatic hormone receptor positive and hormone receptor negative breast cancer. There are currently 2 PARP inhibitors which are approved in the treatment of metastatic disease, and it's worth reviewing the mechanism of action since the biology behind their activity is truly fascinating. We all recognize that normal cells experience DNA damage, and that repair occurs through base excision using PARP enzymes or homologous repair using the BRCA pathway. In patients who have BRCA mutations, there is still repair through base excision repair and PARP. But if you have a BRCA mutation and if you inhibit the PARP pathway, there is no repair and there is cell death. So Olaparib was the first PARP inhibitor approved, and the study design leading to its approval is summarized here. Patients had stage 4 disease, documented BRCA1 or 2 mutations. They had received at least 2 prior chemotherapy regimens for advanced disease, and if you were hormone receptor positive, had to have received at least 1 prior endocrine therapy. Patients were randomized to Olaparib, 300 milligrams twice a day, or standard therapy, and the primary endpoint was progression-free survival, with secondary endpoints of safety, overall survival, response rate, health, quality of life, and second progression. The data are summarized here. Progression-free survival favored the Olaparib arm over the standard chemotherapy that was selected by the physician's choice. If we look at progression-free survival, it was 7 months compared to 4.2 months. 12-month progression-free survival, 25% versus 15%. So this study led to the approval of Olaparib. The second PARP inhibitor is Talazoparib. Its mechanism of action is as a PARP inhibitor. It uniquely traps the PARP DNA complex, which may make a difference in its efficacy. That's yet to be proven, though. The IMbrca study results are shown here, and the study design is identical to the previous study. It is Talazoparib compared to physician's choice of chemotherapy. And as we see, the progression-free survival of 8.6 months with Talazoparib was superior to chemotherapy, 5.6 months. So the NCCN recommendations for the use of PARP inhibitor is to assess germline BRCA mutations in all patients with recurrent metastatic disease. I think there's been some resistance to being able to adhere to this guideline, as sometimes genetic testing may not be approved by some of the insurers. The American Society of Breast Surgeons feels that BRCA testing should be performed on all patients with breast cancers, but the data really do support performing BRCA testing in any patient with metastatic disease. So while Olaparib and Talazoparib are FDA indicated for HER2-negative disease, the NCCN panel actually supports the use of PARP inhibitors in any breast cancer subtype associated with a germline mutation in BRCA1 or BRCA2. In the hormone receptor positive arena, the newest agent is Alpelisib. Alpelisib is a PIK3A inhibitor. This is the SOLAR study design. Women with postmenopausal hormone receptor positive advanced breast cancer with a good performance status were randomized to receive Alpelisib or fulvestrant. And patients were subcategorized according to whether they had a PIK3A mutation or whether they did not. But the treatment was the same, fulvestrant alone versus fulvestrant with Alpelisib. The primary endpoint was progression-free survival. The secondary endpoints are summarized here, overall survival, of course, being one of them. If we look at progression-free survival for Alpelisib, those patients who had a mutation in PIK3A had an improvement in progression-free survival compared to those individuals who did not have a PIK3A mutation. If we look at another endpoint, the overall response rate, not only was progression-free survival in favor of those women receiving Alpelisib, but the response rate was roughly doubled with those patients who received Alpelisib in conjunction with fulvestrant, and clinical benefit was also significantly higher, 46% versus 32.9%. So alpelisib is an important drug in improving progression-free survival for patients with a PIK3A mutation. It's important to talk about side effects because as we review guidelines, it's not merely efficacy, which is important, but also toxicity. And hyperglycemia is very common, 63.7% for patients receiving alpelisib compared to 9.8% in the control arm. The time to development of hyperglycemia is anywhere from 2 to 15 days. Diarrhea is also a problem. It occurs between 2 and 46 days, and diarrhea is 57.7% with alpelisib compared to 15.7% in those not receiving alpelisib. And rash is another significant problem, which can occur up to 12 days is usually the median time to development of it, and it can be grade 2 and 3. Because of this, we prophylactically administer antihistamines to these patients, and the incidence was 35.6% compared to 5.9% receiving fulvestrant alone. So I think the treatment of hormone receptor positive breast cancer provides a number of challenges to guideline adherence right now because as time goes on, there's more and more data. We all accept that the CDK4/6 inhibitors have established benefits in hormone receptor positive metastatic breast cancer. And our guidelines currently do not endorse one over the other. And yet, as time has gone on, we are faced with reports of improvement in overall survival with abemaciclib and with ribociclib. I think another challenge to guideline adherence is exemplified by alpelisib, which unquestionably shows a progression-free survival advantage for women with a PIK3A mutated breast cancer. However, there are additional challenges for managing the side effects for both the patient and the physician. And then how does one balance toxicities with a 5-month improvement in progression-free survival? So the current guideline recommendations for hormone receptor positive breast cancer is to start with endocrine therapy and a CDK4/6 inhibitor. With disease response and progression, check a PIK3A status. And if there is a mutation, consider fulvestrant with alpelisib. If there is no PIK3A mutation, then consider endocrine therapy with everolimus. Guidelines are really important. They provided us the coverage to use biosimilars instead of brand names. They help us to understand the data which led to FDA approval in the targeted populations. And they really are very helpful, especially to clinicians whose practices include many, many different types of cancers. But guidelines ultimately do not replace the need to be a clinician, and they do not replace the need to engage the patient in the decision making, because ultimately you're going to adhere to the patient preference with that understanding. I'm just going to conclude with guidelines for treatment in time of COVID, and most of the treatment guidelines of breast cancer during COVID have really been addressing the newly diagnosed patients. But the obvious treatment changes in metastatic patients is really to try to minimize myelosuppression. We don't want our patients to get immunocompromised more than necessary to expect the response. And so we've had an increased use of growth factors, and we really need to continue to optimize palliative symptoms, which is the most important sort of goal of treating metastatic breast cancer patients. Thank you, and we'll take your questions.
Thank you very much. We're going to have a couple of question and answer session here with Dr. Mortimer in just a moment. So, Dr. Mortimer, we have a couple of questions from attendees. In the HER2 CLIMB study, why was trastuzumab included in both arms if the eligible patient already had progressed following previous trastuzumab and TDM1?
Yes, this is really an excellent question. First of all, the answer is that it was based on their phase 1b data. So that the trial that led to the design of the HER2 CLIMB study actually looked at their phase 1b data, which used trastuzumab together with capecitabine and merely added tucatinib. I think now that the drug is approved, I think all of us are sort of trying to figure out, well, people frequently have capecitabine. Are we going to, not use capecitabine and so on? But the study design is what it is, unfortunately, and that was the rationale for just adding tucatinib to trastuzumab and capecitabine. But I think the bigger question is how we manage HER2 positive breast cancer as disease progresses. So this is one of the few times in medical oncology where we use a drug when the patient's disease has grown already through it, and that's trastuzumab. And the basis of continuing trastuzumab is actually a number of randomized studies that took drug X, like gemcitabine, with or without trastuzumab in women whose disease had progressed on previous HER2 therapy. And the bottom line was that progression-free survival was always improved by the addition of trastuzumab. So that immunologic effect or synergistic effect that we see with trastuzumab continues even in women who have disease progression on a trastuzumab-containing regimen. The second half of the question about progressing on TDM1. So TDM1 is a totally different drug than Fam-Trastuzumab Deruxtecan. So the sort of engineering is the same. We have Herceptin or trastuzumab that goes to the HER2, binds onto it, and then delivers the payload. And intuitively, you wouldn't think that Herceptin would still be binding to that HER2 extracellular domain if the disease has progressed on a drug like TDM1, but in fact that's not the case. Trastuzumab continues to be able to deliver to that extracellular domain and deliver a different payload. So there's a lot we don't understand about trastuzumab resistance, and we're learning an awful lot about these antibody drug conjugates, but TDM1 and trastuzumab deruxtecan are really two different drugs, and patients who progressed or didn't respond to TDM1 went on to respond to trastuzumab deruxtecan. So they really are there's no mutual cross resistance. They are different drugs.
Okay, great, thank you. Another question from an attendee. Did you say ET plus everolimus is an option in PI3K negative metastatic patients?
So
did that correctly?
Yes, that is true. So right now the NCCN guideline is that first-line therapy is CDK4/6 inhibitor with endocrine therapy. If the patient has not had a CDK4/6 inhibitor and they have disease progression on a single agent endocrine therapy, then a CDK4/6 inhibitor becomes second-line therapy. But the subsequent treatment after a CDK4/6 inhibitor is dependent on the PIK3 mutation. And so patients who have a PIK3A are considered candidates for fulvestrant and alpelisib, whereas patients who do not have the PIK3A mutation then are candidates for everolimus in conjunction with a subsequent endocrine therapy.
Okay. How manageable are the toxicities from Fam-Trastuzumab?
Deruxtecan, yes.
Thank you, Deruxtecan.
Yeah, thanks,
I knew I was going to have trouble with that.
Yeah.
So you can talk about the manageable toxicities?
This is clearly a drug that we're always going to refer to by its brand name, unfortunately for all the CME people, because it's so hard to get it across. But yeah, so Fam-Trastuzumab Deruxtecan really became clinically used since January. And as you know from the presentation, the side effect we worry about is interstitial pneumonitis. I have yet to see it. So, I know it exists, and it seemed to occur more often in women who were receiving the higher doses of the drug. But I think the side effects that are most dominant as we've started to use the drug is a fatigue. So this is a very fatiguing drug. And I recently had to stop the drug because a patient literally was bedridden for the full cycle of her treatment. And so, what are we accomplishing? The other thing that's sort of interesting is a number of women that we've treated have had elevations in their tumor markers. Now, as you remember from the waterfall plot, this is like the most enviable waterfall plot of response to any drug in the history of mankind. It is, 160 out of 164 patients, responded, had some evidence of tumor regression. So recognizing that, when I started to use this drug, I would think, well, most people are going to go on to have a response. But it's interesting that we've seen a number of patients who have marker elevations, and their markers go up before you see them go down and on this drug. And so that's sort of interesting. Constipation is a common problem. I think we think about, well, it's from their Zofran, it's from their antiemetic regimen, but in fact, the drug has an incidence of 35% constipation, and I think we've seen a lot of patients who complain about that.
Okay, thank you. Could you speak about the appropriate medical management for patients on alpelisib?
Yeah, so alpelisib is, every time we get a new drug, we have to figure out how to manage those side effects, because the patients who participate in clinical trials are by and large, pretty healthy people with a good performance status. Most certainly in the trials that I presented earlier had performance statuses of 0 to 1. Now you start to treat patients in the real world, patients who have comorbidities. I think alpelisib has provided a lot of challenges in how to manage patients because of the insulin resistance that occurs. So having a PIK3A inhibitor, it specifically causes tissue insensitivity to insulin. And so this insulin resistance is a real problem. It's not uncommon to have patients admitted with DKA. And for that reason, we really need, we've made it a policy that all of our patients on alpelisib see a diabetologist, see some endocrinologist, so that they know how to measure their blood sugars, and they're aware of this. Now, the lowest blood sugars generally occur after 2 weeks, so you have time to sort of train patients and make them aware of the side effects and the concerns with this drug. But that's where we first start. We always have them have diabetes training. The second thing is the rash, which can be a really formidable and uncomfortable rash. And so all patients receive an antihistamine twice a day when they're on this drug. And the third area is the diarrhea, and that actually occurs and then can resolve over time. But it's really important to engage the patient in their own management on alpelisib, because there are so many funky side effects that may occur when they're home taking these oral medications. So.
Okay, great. We have time for one more question here. What data would be useful in helping differentiate between PARP inhibitors or drugs in the same class with similar indications?
Okay, so I think it's a really good question to ask, because the PARP inhibitor trials, the AMBRACA trial and the Olympia trial, they both looked at 2 prior treatment regimens before the patient was given a PARP inhibitor. I have to say that in my own sort of personal practice, recognizing that those studies showed improvement in progression-free survival with the PARP inhibitor, and that PARP inhibitors are so much easier to tolerate than weekly paclitaxel or gem-carbo, that I tend to use it as second-line therapy. And I use it as second-line therapy because when we started the PARP inhibitor trial development, a lot of times patients would get a platinum-containing regimen with gemcitabine, and if they were not assigned to the PARP inhibitor, then they were allowed to cross over and get the PARP inhibitor. So in a sense, they were second-line therapy patients. And I think that because of quality of life being ultimately the most important endpoint here, and progression-free survival, which favors the PARP inhibitor, I think most people are using them farther up front as second-line therapy and even first-line therapy in some cases. The other unique thing about the PARP inhibitors is that there are these exceptional responders. I currently follow a woman who's been on Talazoparib, which is not FDA approved yet, and she's had documented pulmonary metastases for literally 12 years and continues in complete response. And I have another woman who was on the PARP trial who, progressed after initial response to chemotherapy, and she's 3.5 years on Talazoparib. So because of these exceptional responders that show up in these PARP inhibitor trials, it's hard not to want to use them earlier on in the treatment of patients with BRCA1 and 2 mutations.
Great, thank you so much.